Welcome, everyone. My name is Dr. James Watterson. I am one of the urologists working at the Ottawa General Hospital. I've been involved with this lecture series for the last 5 years and helping to organize. Traditionally, we've been able to do this in person. However, with this year's disruption to the operating room schedule due to COVID, more than half of us are currently in the operating room. And as such, we're putting together a series of talks, recorded talks to you to still provide you with the information for self-study. The lecture series will consist of 5 or 6 talks geared towards practical aspects of urology. My talk is the practical approach to urolithiasis. As I said, I'm currently associate professor at the University of Ottawa. I'm currently the vice chair of education for the Department of Surgery. I've been in charge of the lithotripsy and kidney stone program since 2002 after returning from a fellowship in endourology at the University of Western Ontario. I did my residency here in Ottawa from 1995 to the year 2000. So I hope to provide you with a practical approach to kidney stones and urolithiasis, and I hope you find that the talk is informative and helpful to you in your future practice. I have no financial disclosures. So the objectives of today's talk really will cover the full gamut of urolithiasis, starting with the clinical presentations of urolithiasis, epidemiology of urolithiasis, imaging modalities for urolithiasis, indications for possible referral to urology, review of the treatment options for patients with urolithiasis, and lastly, prevention of urolithiasis. As I said, I've really tried to approach this from a very practical, useful standpoint, reflecting on some of the lessons learned over the years and little pearls of wisdom that I think will be helpful to primary care physicians. So to start, I thought we would start with a very common clinical vignette, clinical presentation that we see quite frequently in urology. So a 38-year-old female with a history of Crohn's and a smoking history was found to have 2+ blood on an annual urinalysis and dipstick performed in your office. And the question is, what's the significance of this? It's a very common reason for a referral to a urologist, and this does provide us with an opportunity to review the significance of this. So the AUA guidelines have really outlined and defined what asymptomatic microscopic hematuria. Hematuria is defined as the presence of red blood cells in the urine, and when visible to the naked eye, it is termed gross hematuria. When detected by the microscopic examination of the urinary sediment, it is termed microscopic hematuria. It's important to note that the dipstick method to detect hematuria really has limited sensitivity and specificity. So sensitivity of 95% and specificity of only 75% for detecting microscopic hematuria. There are obviously potential false positive readings due to other aspects and other issues, including dehydration and exercise. So it's really important that if there's blood detected on the dipstick, that microscopic evaluation and examination of the urine is performed. And with this, microscopic hematuria is then defined as greater than 3 red blood cells per high-powered field. So with this in mind, a follow-up to the urinalysis is performed, and there are 3 red blood cells per high-powered field. So what investigations does this typically prompt? The CUA guidelines have a nice little algorithm here that really sort of prompts you to look for any historical aspects that might lead to a false positive. If there are no potential other reasons for the hematuria, you're also looking for potential findings of glomerular disease, such as significant proteinuria. Again, if none of those exist, then we go down the pathway to investigate the hematuria. And so generally speaking, evaluation of hematuria involves an upper tract assessment as well as a lower tract assessment. In the setting of gross hematuria, this would require a cystoscopy for the lower tract assessment with a CT urogram. For microscopic hematuria, we generally would perform a cystoscopy as well as an ultrasound. So to really sort of summarize those AUA guidelines, hematuria categorized as either gross or microscopic. A positive dipstick for hematuria requires confirmatory midstream microscopic urinalysis. And then obviously a thorough history and physical examination looking for risk factors for urothelial carcinoma, which are then utilized for risk stratification. And generally speaking, lower tract and upper tract assessment with cystoscopy and imaging, depending on whether it is gross or microscopic. So in this particular case, urine culture was performed, which failed to demonstrate any growth. Urine cytology, voided urinary cytology was negative. Cystoscopy performed by the urologist was negative. And an ultrasound really revealed only a 6 millimeter non-obstructing stone in the left upper pole. It's important to note that one of the sort of the hallmark findings of a stone is the presence of shadowing. There are many other potential comments made by radiologists to suggest a stone, but I'll review in a future slide how some of these findings may be problematic. So urolithiasis, how significant is it? What are the current stats and the epidemiology of stone disease? How do stones present? What type of stones are there out there? And what are some of the risk factors for stone formation? What's the likelihood of finding a stone that will likely become symptomatic? And currently, if it passes into the ureter, what's the likelihood of it passing spontaneously, which will help to, us to counsel patients and to help to stratify whether or not they need to have intervention. And lastly, what are some of the indications for referral to urology? So some of the epidemiology of urolithiasis, my practice is comprised of probably 90% of stone patients. And I have a very busy practice, and I foresee myself being busy for the next decade until retirement, with really no signs of slowing down. So the overall lifetime risk of stones is quite significant at 9% and is increasing. The fourth to sixth decade is the more common age of presentation. That being said, I have looked after patients as young as 2 years old, all the way up to patients in their 90. There has been typically a male to female preponderance. However, this gap is narrowing. Environmental factors are significant, with obviously hotter, drier climates having higher prevalence. Occupations that lead to dehydration are obviously important to delineate and to tease out in your history as well. There's a variety of other systemic factors, obesity and increasing BMI, presence of diabetes mellitus, metabolic syndrome, are all risk factors for the formation of kidney stones. And there's a significant economic burden. Just in the U.S., in a study that was performed about 5 years ago, it was estimated that $1.8 billion per year can be attributed to the treatment of kidney stone disease. Some of the presenting symptoms, first of all, a stone can be entirely asymptomatic. The common symptoms that we see include the typical renal colic or flank pain. But it really depends on where the stone is presenting in the ureter. Pain can be felt anywhere along the course of the urinary tract, from the kidney in the flank area around to the front lower quadrant, and they may have, in fact, signs and symptoms of bladder irritability in the absence of any urinary tract infection. Obviously, there can be associated nausea and vomiting, presence of blood in the urine, either microscopic or macroscopic. It is important to note that some stones will not show any evidence of blood as well on urinalysis. In rare cases, we have patients that present with stones obstructing both sides, which can lead to obviously kidney failure. And as I said, the stones themselves may be entirely asymptomatic, both in the kidney as well as in the ureter. There's obviously a host of different stone types and crystal composition. 80%, however, of the stones are calcium-based, either pure calcium oxalate or a mixture of calcium oxalate and calcium phosphate. Only 5% of stones are pure calcium phosphate, and that can sometimes lead to a diagnosis of primary hyperparathyroidism or a condition called renal tubular acidosis, or potentially in patients that are taking a certain medication called topiramate, which can lead to almost an acquired type of renal tubular acidosis. Magnesium ammonium phosphate are the struvite stones. They're associated typically with a urinary tract infection, and there's a higher, obviously, prevalence in females who have a higher risk of urinary tract infection. We do see these obviously in patients that have issues with neurogenic bladders and have chronic catheterization or chronic colonization of the urinary tract. Uric acid stones, we see in about 5 to 10% of the time. These are radiolucent on plain film imaging. The purely genetic stone, which is a cystine stone, is seen in only about 1 to 2% of kidney stones. So what are some of the risk factors for stone formation? Obviously, diet's a big one, especially in North America. We typically don't drink enough as a society, so dehydration's a big issue. Some patients have a higher protein intake and a higher salt intake, and there are certain foods that are higher in oxalates. So the dietary counseling really is geared towards these specific issues. Looking for other reasons for dehydration, so occupational history is important, and then a past medical history, looking for those conditions that increase the risk of subsequent stone formation, such as inflammatory bowel disease with either Crohn's or ulcerative colitis, if there's a history of gout, and lastly, if there's a history of hyperparathyroidism. So the natural history of asymptomatic chalazial stones, we see these all the time, these small stones that are picked up on some form of imaging, either ultrasound or CT scan. So what happens to these stones if we track them? Well, I think the sort of the easiest way to think about these is that there is a significant chance that these stones over time will start to give symptoms or potential complications. I typically use the 50% chance over 5 to 10 years that they will start to give patients problems. So if there's a desire to observe these stones, then periodically tracking them to look for any stone growth, and obviously screening for any development of any symptoms, I think is an important aspect of long-term follow-up. When a stone passes into a ureter, there's the question about whether or not a stone can be managed conservatively. So it's important to note how we will predict or how we will sort of look at the probability of stone passage. It really depends on a number of factors. Obviously, the size of the stone. Again, generally speaking, the larger the stone, the less chance that it will pass spontaneously. Generally speaking, as a stone gets over 6 millimeters, the chances of passing spontaneously becomes quite low, at 20% or less. And also where in the ureter it presents. So stones that present early on in the upper part of the ureter have a less chance of passing spontaneously than those that present with stones located in the lower part of the ureter. The degree of hydronephrosis, I think, is important, and it usually reflects the chronicity of the obstruction. So a stone that drops in acutely and has not been in the ureter for a long period of time will usually have only mild hydronephrosis if a stone's been present in the ureter for a longer time, with a longer time to develop more significant hydronephrosis. The degree of hydronephrosis will help to determine how long the stone has been present in the ureter. It's important to reflect on some of the indications for referral to urology. Obviously, in the setting of any ongoing symptoms such as pain, nausea, vomiting, hematuria, or recurrent urinary tract infections associated with the stone. If a patient has recurrent stones that are either large, multiple, bilateral, I think it's important for a urology to assess the patient. If there's any impact on the overall kidney function, or if there are concerns with a stone in a solitary kidney or the presence of obstruction. Patients that are obviously pediatric patients warrant an investigation and evaluation by pediatric urology or nephrology. Some occupations, such as pilots or those in the military, require all stones to be treated before they're able to resume active duties. If the stone is obviously unable to pass spontaneously or unlikely to pass based on the potential probabilities of passing spontaneously, then urology should get involved earlier than later. And lastly, patient preference. Some patients who have experienced a prior stone passage episode or frequent travelers, some of these patients do request prophylactic or preemptive treatment of their stones. So in this clinical vignette, the patient opts for conservative management. 2 years later, she presents with lower urinary tract symptoms, classified as frequency, urgency, minimal dysuria, with some vague left flank discomfort. Repeat urinalysis reveals the presence of 2+ blood, positive leukocyte esterase, but negative nitrates. Patient is prescribed 10 days of Septra, but following completion of the antibiotics, the symptoms persist. Repeat ultrasound demonstrates mild left hydronephrosis, but no renal or ureteral stone is seen. So a couple of questions just to ponder. Is a second course of antibiotics indicated? And I guess another thing to ponder, was the first course of antibiotics indicated? What are the advantages and disadvantages of various imaging modalities for urolithiasis? Imaging for urolithiasis has changed over the years from my training, so over the past 20 years. The plain film is still widely used X-ray modality that is quite convenient to obtain and is helpful. It does only obviously pick up radiopaque stones. It does not provide any information on the collecting system anatomy, but it is useful to screen for candidacy for ESWL, something I'll touch upon in later slides. The intravenous pyelogram is historical. It does use contrast, but is no longer in use. Renal ultrasonography is obviously widely used. It does give us some anatomical information. There's absence of any radiation. The challenges are that the ultrasound has poor visualization for ureteral stones and smaller stones, less than 2 to 3 millimeters. There's often an overestimation of the stone size. It is used for a follow-up modality. Unenhanced CT scan is really sort of the gold standard. It helps to delineate the burden of stone, the location of stones, the relevant anatomy and relational anatomy. There are also calculations and measurements that can be performed on a CT scan that can be helpful with predicting outcomes for shockwave lithotripsy, as well as to help with surgical planning. Can sometimes help to predict stone composition through the measurement of what we call Hounsfield units. And the current protocols typically are very low dose, usually only about 2 to 3 millisieverts per low dose non-contrast scan, with the average annual safety of 50 millisieverts per year. So it's a very, very safe modality. As I stated, plain film imaging is still used widely. I use this quite significantly in my my clinical practice. It's easy to get an X-ray on the day of a patient's clinic visit. And it's really predicated on the fact that 80% of stones are calcium-based. So if the stone is calcium-based and large enough and has enough calcium in it, then we may be able to pick it up. It does, however, have limited sensitivity, which basically means that it can potentially miss smaller stones. I use it a lot for a follow-up modality. If the patient is known to be a calcium stone former, there's a low cost associated with a very, very low radiation exposure. It is a very useful adjunct to ultrasound, both for clinical follow-up and to help determine candidacy for ESWL. ESWL is performed only on calcium-based stones, so it's important to note whether or not we're able to see this on a plain film imaging, because we do not use ultrasound to target stones. As I said earlier, it's easy for us to get an X-ray on the day of a clinic visit in the hospital when a patient is visiting me, whereas an ultrasound is, again, has limited sensitivities, as well as it may miss stones in the ureter. So it's not really a great adjunct or imaging modality when a stone is being actively tracked. If the stone is not visible on a CT scan, I find that also an adjunct KUB may still be able to pick up that stone, and again, for the same reasons, with ease of follow-up and to also help determine the candidacy for ESWL. Some of the specific features of stones on KUB, depending on the chemical composition, some stones are very, very dense. So the calcium oxalate monohydrate and calcium phosphate stones are very, very bright. They're very, very dense. These are the stones that are very hard and are more refractory to ESWL. The calcium oxalate dihydrate stones are very brittle. These tend to respond very, very favorably to any of the interventions. Struvite stones have slight radiopacity to them. These typically are more seen in a staghorn configuration. Cystine stones being rare, 1 to 2%, they are faintly radiopaque, and then uric acid stones are radiolucent or non-opaque. Ultrasound is used, obviously. It's a ubiquitous form of imaging modality for stones. It's easy to get. It provides some anatomical information that we don't see on plain film imaging. It's cost effective, and obviously it's no radiation. I find that it's useful as a screening modality, but because of the lower sensitivities and specificities, a lot of the times I will require further imaging for a patient who is referred to me with an ultrasound. Typically a CT scan is required, or at the very least KUB as an adjunct to the ultrasound to help provide that additional information that I can use to better triage and counsel a patient regarding treatments. It does overestimate the stone size by approximately 20%, so it's important to take that into consideration. We use a lot of ultrasound, obviously, in the pediatric realm, as well as it's the first-line modality of imaging for pregnant patients. Should be noted that in cases where we're dealing with renal colic in pregnancy, if an ultrasound is not able to provide us with the necessary information to help treat a pregnant patient, a low-dose CT scan is often done, even during pregnancy, if necessary, to make the diagnosis. So a CT scan obviously is the sort of the gold standard for imaging. Has a very, very high sensitivity and specificity, so it will give you the answer typically. Presently, these are non-contrast low-dose scans, so there's no need for any intravenous contrast, It detects all stones, both in the kidney and the ureter. Generally speaking, the protocol is such that the images are performed at 2 millimeter slices, so there's a high detectability. It does give us information regarding stone burden composition, which can help to greatly facilitate treatment planning, and I have stated before about the radiation exposure. So in this vignette, a non-contrast CT scan is performed, which demonstrates a left distal ureteral stone measuring 6 millimeters times 8 millimeters with moderate hydronephrosis with perinephric stranding. KUB is also ordered, which does demonstrate the radiopaque stone. So some of the learning points, I think, in this vignette, that distal ureteral stones can mimic urinary tract infection symptoms, usually with less dysuria. Obviously, a culture and sensitivity is required to rule out a urinary tract infection, and that a KUB can also help to determine the candidacy for ESWL. So treatment options for urolithiasis, they run the gamut from conservative therapy all the way up to the most invasive form of therapy, which is percutaneous nephrolithotomy, reserved for the larger stones. Medical expulsive therapy using alpha blockers, we'll touch upon that. It has been somewhat controversial and has sort of fallen in and out of vogue over the past number of years. I still use it for a certain subset of my patients, and if I had a stone myself, I would also use it personally. And then lastly, we also have the extracorporeal shockwave lithotripsy and ureteroscopy methods. So a couple of questions. What is MET and what are the expected results? And what are the indications for the other treatment modalities? So medical expulsive therapy really sort of came into practice probably about a decade ago, and is based on the physiology of the distal ureter, where there are alpha adrenergic binding sites in the distal ureter. So similar to the prostate smooth muscle that has alpha receptors. We use alpha blockers to relax the smooth muscle of the prostate to help with men with obstructive voiding symptoms. Similar sort of notion that if we can block these receptors, we can result in smooth muscle relaxation with decreased ureteral contractions and peristalsis that can help to facilitate stone passage. So based on the CUA guidelines of 2015, so about 5 years ago, medical expulsive therapy with alpha receptor antagonists, tamsulosin is the most commonly utilized agent, potentially shortens the duration and increases the likelihood of spontaneous stone passage. So consideration should be given to offering it to patients with distal ureteral stones less than 10 millimeters in size. That is presently how I utilize it. There have been subsequent studies performed, and this is a clinical practice guideline for the use of alpha blockers for uncomplicated ureteric stones that was recently published just a couple of years ago in the British Journal of Urology. And basically, I think that the take-home points, practical issues at the bottom, that alpha blockers as medical expulsive therapy is an off-label use of this drug class, and the duration of use is typically about 4 weeks or until stone clearance, with the use of tamsulosin as the most commonly prescribed alpha blocker. What are the potential benefits? Well, the panel that reviewed the data basically felt that, again, there's the potential benefit with a small decrease in the number of pain episodes and small reduction of hospitalizations, with the potential small increase in stone clearance rate that generally outweighs the risk of adverse events with alpha blockers. So again, I typically will utilize the medical expulsive therapy for patients with distal ureteric stones that are over 5 millimeters. I believe that this is likely the sweet spot where we can still offer this to patients. Moving on from medical expulsive therapy, we're now into sort of the active forms of therapy. So ESWL, or extracorporeal shockwave lithotripsy, is a treatment that's been around since the 1980s, which really just uses these focused high-pressure shock waves or sound waves. And at the interface of soft tissue and stone is where we actually get the pressure wave affecting the stone itself. Generally speaking, it's for smaller stones, so kidney stones less than 2 centimeters. Even that's probably getting up there in size. So my own practice would be a stone less than 15 millimeters. It can be utilized for stones both in the proximal and distal ureter, although obviously with advances in ureteroscopy, we're able to access really any part of the urinary tract now via flexible endoscopic instrumentation. The benefits of shockwave lithotripsy is that it is an outpatient form of treatment. It's non-invasive. It's done under sedation alone, so patients do not require an anesthetic with reasonable results. Also, patient satisfaction is higher with shockwave lithotripsy treatment compared with ureteroscopy. Even though ureteroscopy has a higher stone-free rates, patients do like the non-invasive nature. Generally speaking, we're able to get patients into a booking within 2 to 4 weeks. Our lithotripsy center here in Ottawa is housed at the Riverside campus. The other centers in Ontario include both Toronto and London. There's also a lithotripsy treatment center in Montreal. So it's not accessible in all centers, of course. So some of the contraindications why we can't perform ESWL: if a patient has an untreated bleeding diathesis, if there's untreated infection. Pregnancy is an absolute contraindication to the use of shockwave lithotripsy. And obviously, if there are obstructions distal to the stone, such that the fragments will not pass out, then obviously we have to look at other methods of intervention. So again, just a picture here about what the shockwave unit looks like. This is an older picture of a patient. As you can see, that there's the patient's actually intubated. Presently, we do not require any anesthetic. It's just conscious sedation, such that the patient's still awake and able to talk to you if necessary. Let's see if this video works. Perfect. So this is just a picture of a stone being actively treated while being viewed from through a ureteroscopic standpoint. So you can see these successive pressure waves that are impacting on the stone, resulting in fragmentation. And the hope is that we are able to fragment the stone well enough that there will be subsequent evacuation of the stone fragments. When stones are on the larger side, so typically, again, stones over the 2 centimeter threshold, or stones in the lower pole over 10 to 15 millimeters, we may recommend what we call percutaneous nephrolithotomy, which is a surgical treatment that happens in the operating room. Generally speaking, what we do is under fluoroscopic guidance, we puncture into the kidney and we establish a tract through the renal parenchyma into the collecting system where the stones lay to facilitate direct extraction of the stone fragments. So these are a couple of snapshots of fluoroscopic. So we're targeting percutaneously through the flank using a needle going through the parenchyma and accessing down into the hollow collecting system where the stone resides. Once we are in the kidney itself, a guide wire is established from the outside world down into the inside world. This then allows us to place a balloon dilator down into the system, and a subsequent hollow sheath is then passed over the balloon into the collecting system, which in effect sets up a channel or hollow tube or passageway down into the collecting system where the stone resides, so that we can facilitate fragmentation and removal. So the balloon itself is being blown up with subsequent placement of the hollow tube down into the kidney. This is obviously for a more extensive. Most times we would have only a single passageway into the kidney. For this stone, it required placement of 3 separate tracks into the kidney. We're then able to fragment the stone using a variety of different lithotripsy methods. This is an ultrasonic lithotripsy device. Basically, it's a mini jackhammer that's vibrating at a very high frequency, and a suction is applied so the fragments are evacuated out through the hollow probe. Again, this is reserved for typically larger stones. At the end of the procedure, we leave a little drainage tube overnight, or the patient is placed with an indwelling ureteral stent. Most patients, it's an overnight stay. The last surgical option for treatment of urolithiasis is ureteroscopy. So again, it's usually reserved for stones in the ureter or smaller stones in the kidney. Generally speaking, a guide wire is established into the kidney with subsequent passage or loading of our flexible ureteroscope up the ureter into the kidney. We are then able to evaluate the entire inner aspect of the kidney, both using the help of fluoroscopy as well as a video monitor. Once the stone is detected, a laser is employed through the scope. This is a holmium YAG laser, which has been in use since the late 1990s and allows us to treat these stones through the smaller instrumentation. The fiber itself is about 200 to 300 microns. So this is treatment of a stone in the ureter. So back to our vignette. She's placed on medical expulsive therapy. 2 weeks later, while you're recovering a shift in the emergency room, she presents with increasing left flank pain, persistent lower urinary tract symptoms, and fever. On physical examination, there is evidence of a documented temperature, 38.9, with tachycardia and some relative hypotension. So, question for you is, what is your diagnosis and what is your management? So these are the things that get us out of bed. So a septic stone is the potential diagnosis here. So assessment of the acute stone episode involves obviously taking a history, looking for signs of any infection, so fever, tachycardia, hypotension, raises the suspicion for obstructive pyelonephritis or urosepsis. Supporting lab work, including CBC, looking for leukocytosis, creatinine, urine studies, looking again for nitrate positivity, and then urine cultures and blood cultures in the case of a patient that is demonstrating some signs of urinary tract infection or urosepsis. Radiographic evaluation is a necessity. So in this case, a definitive diagnosis is important. So the use of a non-contrast CT scan, I think, is vitally important. So if you're covering a shift in the emergency department, I would certainly advise for these stone patients use of a CT scan to definitively make the diagnosis. I think is very, very helpful. I think for patients that have had recurrent stones, that know that they're experiencing a stone episode, ultrasound would certainly be a reasonable starting point. Many times, however, we do have to go on and request CT scans, so it sometimes makes better sense to obtain the CT scan right out of the gate. Pain control is obviously important. There's been a shift away from opioid medications to more non-steroidal. It's important to note that non-steroidal anti-inflammatories, they actually provide better reduction in pain scores compared to opioids. Ketorolac or Toradol is a wonder drug in my estimate for kidney stone attacks and colic. If there's evidence of obstructive pyelonephritis or urosepsis, this is an emergency. This does warrant request for consultation from urology. Do not send your patients home. Again, there's a mortality potentially associated with this. So we typically would initiate broad spectrum antibiotics, and then we're looking for decompression of the urinary tract, either with placement of a ureteral stent in the operating room or a percutaneous nephrostomy tube through interventional radiology. We've talked a little bit about these issues already with respect to spontaneous stone passage, as well as the indications for admission to urology. So this patient undergoes ureteral stenting by the urologist and treatment for UTI with a 2-week course of antibiotics. The urologist now performs a subsequent ureteroscopy 4 weeks later to remove the stone. The patient's now stone-free. Patient is now requiring about stone prevention. So some of the aspects to discuss: what's the chance of stone recurrence, what further evaluation can be performed, in what groups, and what interventions are available to reduce recurrence, and what follow-up is required. So why and how to prevent recurrence? Again, the risk of recurrence is significant, 50% at 5 to 10 years, if the patient does nothing different. So at this point in time, once I've treated the acute stone episode, I usually will shift gears towards more of a preventative type of strategy. So again, looking for things in the history that would increase the risk of stone recurrences, such as dietary aberrations, the presence of any stone-provoking medications, such as, again, topiramate or Topamax, used as an anti-seizure and anti-migraine headache. Looking for risk factors for dehydration, fluid loss, whether there's a history of recurrent urinary tract infection. Trying to find out a little bit more about what type of stone they formed. So looking for crystals, the pH may give us some indications. Obviously, if they've passed a stone, collect it, have it analyzed. And then some standard sort of blood work. Again, serum calcium can be used as a screening test. A uric acid level can also be requested. And then review of their imaging. So patients, after their risk assessment, if there are a history of the following family history of stones or gout or chronic urinary tract infection, things that are going to potentially increase their risk of stone recurrences, this generally then will lead to at least a discussion regarding a further evaluation with a metabolic stone evaluation. So metabolic stone evaluation augments the serum chemistry work with the addition of possible PTH evaluation. If the serum calcium is high or high normal, then this would prompt obviously drawing of a PTH. If the PTH is elevated, then this leads us down the pathway towards evaluating for possible primary hyperparathyroidism, with an ultrasound of the thyroid and parathyroid glands, nuclear medicine scanning, and a referral to ENT. 24-hour urine collections are also requested on 2 separate occasions, again looking for aberrations in the urinary chemistry that would potentially increase the risk of stone formation. Things such as higher levels of calcium, higher levels of oxalate, higher levels of uric acid, higher levels of sodium, lower levels of citrate. It's important to note that patients actually want to prevent their stones. So couple of studies that were done in the past really show that patients are interested in finding out why they're forming their stones. They're interested in preventing stones in the future, and they are willing to collect 24-hour urine samples. Now, there are some patients that we know that when we're talking to them that their compliance is going to be low. So I think it's part of the process is to describe sort of what's required. Some patients will tell you right out of the gate that they're not interested, or that the chances of them actually successfully completing the 24-hour urine collection is going to be low. In those cases, it really then leads to really the focus on the dietary aspects of stone formation. So, dietary recommendations for stone prevention. Again, avoidance of any stone-provoking meds. We've touched upon that. Really trying to change the patient's lifestyle and habits. High fluid intake is required, enough to establish and maintain a urine volume of at least 2.5 liters per day. A general rule of thumb is that the color should be a very pale yellow to almost clear. And with this alone, we can reduce the chance of stone formation dramatically over a 5-year period of time. We can add further dietary recommendations, including moderation of intake of foods that are higher in oxalate, such as the dark green leafy vegetables such as spinach and rhubarb. A number of berries, including strawberries, are higher in oxalate. A lot of patients have a higher intake in nuts and peanut butter and so forth, so it's important to exclude those. Limiting sodium intake to less than 2,300 grams, limiting intake of animal protein to less than 6 to 8 ounces per day, which again, general rule of thumb would be half of a palm. It's important that patients maintain intake of calcium. There's a paradoxical increase in stone formation risk in patients that have a very low calcium intake. And then increasing the intake of citrate-rich foods, so lemons, limes, orange juices. Crystal Light lemonade is sugar-free and also has a fair amount of citrate in it. So I usually recommend to my patients to add 4 ounces of lemon juice to a 2-liter jug of water, put that in their fridge, and take a glass of that per day or two, just to increase their intake of citrate. Citrate is basically a stone inhibitor that helps to prevent calcium and oxalate from getting together and complexing. Weight loss is important, as well as diabetic control. For follow-up, if the patient's stabilized, then I typically would say an ultrasound or an x-ray every 2 to 3 years in patients that do not have any stones. If a patient is tracking a small stone, then again, you may shorten that interval. Lastly, obviously, if there are stone recurrences or evidence of documented stone growth or development of symptoms, then re-referral back to urology would be appropriate. So I'd like to conclude by stating that it's been a pleasure to provide this information to you. If you do have any questions, please feel free to reach out to me at any time. I'm happy to review any of the points laid out in the presentation. And again, thank you very much for your attention, and hopefully the talk has been informative for you. Thank you. Merci.